And we checked before, all my slides are here, so. Well, thank you very much. It's really an honor to be here amongst this group. I just have to say it's been fun to see match some faces with names that I didn't know before. So I'm going to try to explain why a pediatric hepatologist, which is a liver specialist, not the reptile person. I always have to clarify that, not a hematologist. I get that a lot too. So I study liver disease, and there's not that many of us. There's probably, 20 or 30 pediatric liver specialists in the country, and then even fewer internationally. But we're needing more and more liver doctors because of fatty liver disease. And fatty liver disease is how I got into sugar research, because there's such a close tie, which I hope to show you today. So fatty, and just ignore the blue part, because I had animations in mind, and those don't show up today. So just ignore the blue part for a second. So fatty liver disease is a condition in which the liver retains fat inappropriately. So a normal healthy liver has less than 5% fat in it. And you can see on the left-hand side of the slide there is a healthy liver. There's a picture of the tissue with a cartoon of the liver just below it. And then in the center, you can still kind of see how the cells are completely displaced by those big round globules of fat. And so it disturbs the liver metabolism, and huge amounts of fat could be stored in the liver relative to what should be there. Sometimes I get pathology readings back that say 95% fat. And that's kind of frightening when a child's 11 years old. So the center one is depicting fatty liver. Now, if the fat in the liver is accompanied by inflammation, you can get fibrosis. Has everyone here heard of cirrhosis? You know what that term is? Okay, very good. So knowledgeable audience, great. End-stage liver disease. Not everybody with fatty liver goes on to end-stage liver disease, but it's a reasonable, a worrisome proportion of people. And on the far right there, you can see a cirrhotic liver. I think what's probably more important, and I'm saying that even as a hepatologist, it's more important that fatty liver disease is a predictor of type 2 diabetes, followed by cardiovascular disease and stroke. And so it looks like the continuum of disease is that fatty liver disease is an earlier phase of the dysmetabolic condition that then leads to type 2 diabetes and then leads on to cardiovascular disease and stroke. And so the rates of association between fatty liver disease and those other morbidities are very high. So why does the liver accumulate fat? And so now we're going to go over this for the third time, so hopefully everybody gets it. So we started with your slide and then Kimber's, so after this there'll be a quiz. But I'm going to look at a little bit different perspective and try to think about it from a whole body perspective as well. So when carbohydrates go into the liver, shown by cartoon number 1 there, they can go to different places. One is that they should be burned, which is 2, or those carbohydrates can go into the mechanisms to make fat. And when you're not burning it, as Kimber pointed out, and you don't need those calories, much of it gets sent into denovo lipogenesis, or the synthesis of new fat. When de novo lipogenesis is upregulated, that fat needs to go somewhere, so it either has to go back and be burned, which is already downregulated, as we've learned, or it has to be exported out of the liver. The ability to export triglyceride out of the liver it's fixed. So we only make a certain number of VLDL particles, or ApoB proteins, every day. So you can't just make more VLDL, which is the particle that carries the triglyceride. Therefore, you can make bigger VLDL, but that only gets you to a certain point. And so people who have upregulated de novo lipogenesis and downregulated burning of fat end up storing fat in the liver inappropriately. And I've shown you what that does to the liver. So fructose, actually I have a quiz question for you. So what drives de novo lipogenesis more than fructose? Alcohol.
Oh.
That's the only thing. So it's alcohol, fructose, and then other carbohydrates. So basically, if you want to drive up the rate of de novo lipogenesis, pick one of those three. So what disease is associated with alcohol intake? Yeah, and they also get fat in the mechanisms of that. So fructose also probably drives inflammation, and sugars drive inflammation through other mechanisms. On the bottom right-hand side there, you can see an intestine, and we don't have all the mechanisms solved in that, and I think that's an important area of research, is the effect of sugar on microbiome. But in our studies, we looked at endotoxin, which is a bacterial product that leaks out of the gut when you have altered microbiome, and the endotoxin levels are strongly regulated in fatty liver disease. So lastly, so does it really matter? So if you look at sugar in people, what do we see? Here on the left-hand side, I'm showing you a 6-month study where they gave people soda, milk, diet drinks, or water. And over 6 months, visceral fat and hepatic fat both went up dramatically, as shown by the left-hand bar in both of those figures. And I just wanted to try to I was looking for data that's really long-term perspective, and the Framingham study has some of the longest assessments in this. And if you look at their data, they showed that sugar-sweetened beverages increase the risk of elevated ALT, a marker of fatty liver, by 30%. And then lastly, does it matter if we reduce the sugar? So, in trying to prove causality here, and in pediatric studies, I have to say we actually don't give sugar. We always reduce sugar and look for improvements, just ethically. So on the bottom right-hand side, you can see a study recently published by Rob Lustig, and he showed that over just 10 days, if you reduce fructose out of the diet completely, that their insulin resistance gets dramatically better. And there were some hints of improvements in the liver as well. So we have ongoing studies in this area. We're looking at if we can reduce the endotoxin, does the liver get better? Because that will help to show causality as well as a potential treatment. And then we're also doing a large randomized controlled, well, it's large for pediatrics, randomized controlled trial of reducing sugar completely in children with NAFLD. So we actually provide the entire family with a sugar-free diet for 2 months, and no artificial sweeteners either. And then lastly, I thought I would just put a plug in for later for research needs. One of the things that we really don't know is how to get people to reduce sugar. So I'm a clinician. I see patients every week, and I'm a sugar expert too, right? And so for the last 10 years, I've been sitting in my clinic. I tell the mom and dads about sugar, and I thought I was doing a good job. But some of my long-term patients are now in this clinical trial where they're being given all of their food that's actually sugar-free, and sneak peek, they get so much better when they're in the study, when they actually are provided sugar-free food compared to when they were just trying to follow my recommendations as their doctor. And so I'm hoping that one of the areas that we'll learn more about is how to help families change their behavior. Thank you.
Stay there, Miriam. Yeah, 3 minutes for questions.
Oh, sure. They reduced sugar in the study, or in a randomized controlled trial of children over 10 days, and saw improvements in insulin sensitivity.
Michael?
Yeah, this is the question I was trying to raise, but it was relevant here too. So there was some discussion this morning about the higher sugar intake in Hispanics and in Mexico. And of course, another key factor in all of this story is the genetic predisposition and the very high prevalence of a gene, 50% in Hispanics, that serves to retain triglycerides in liver. So adding additional not complexity, it's actually a simple story, but it's very relevant, especially given the rise in fatty liver in the Hispanic population.
Absolutely. And if I had had a fourth slide, I would have put up your study showing this very clearly. So it's an epigenetic phenomenon, what's happening with sugar and the liver.
It's not epigenetic necessarily.
Well,
it's a
nutrigenetic
nutrigenetic
interface.
phenomenon. It's turned on by high sugar.
Yeah. So you have to have the predisposition to make fat in the liver. And actually, when I started doing research in NAFLD, my original hypothesis, which I proved null, was that that fructose caused NAFLD. And it doesn't, actually. Fructose causes NAFLD in somebody who's genetically predisposed to have fatty liver. But the problem is 50% or maybe even more of people have predispositions, have genetic polymorphisms that can cause NAFLD. And certain ethnicities have even higher rates. So Hispanics, very high. Asians, the Caucasians, and then African Americans tend to not have the polymorphisms that drive fat in the liver. So some people, when they have excess calories, they expand their subcutaneous fat, so fat in other places. Whereas if you're genetically predisposed to have fatty liver, then having excess calories, particularly from sugar, that's the reason that drives the fat in the liver. So very important.
Yeah, I'm going to expand a little bit about the microbiome part, because it's something we're looking at, particularly the way the interaction.
Can you use the mic?
Yeah, particularly the interaction of microbial products with the brain in driving ingestive behaviors. So clearly, this is a thing that's upstream from all the metabolic changes that have been talked about. But I think it's probably equally important as one component in this problem. And so you mentioned a few times the endotoxemia, so this phenomenon of metabolic endotoxemia, where you have this low-grade immune, like lipopolysaccharide, circulating in the circulation, and that has shown, as you probably know, to make many changes also, not just in the periphery, but also in the central nervous system. They studied in the hypothalamus, so these low-grade inflammatory changes in the hypothalamus, changing the satiety threshold mostly studied in animals. And the interesting thing is that it's really been shown for high fat. All this has been shown in animals with high fat, like the 60% lard diet, with high sugar and with high fructose more than glucose. And some people, always bring up this question of wondering, is this because in these diets there's a dramatic decrease in fiber and complex carbohydrates if you increase these other components? And that's why fat and sugar share these mechanisms, these downstream mechanisms, or if it's really something specific to the fructose or to the glucose. But changes in the microbiome driving this interaction with the host, increasing the permeability, decreasing the mucus layer, increasing intraepithelial permeability, and then leading ultimately to this metabolic toxemia seems to be a common denominator for both the sugar, the fructose, and the high-fat diets.
You're exactly right. There are many shared mechanisms between very high fat and high sugars diets, and so I think you make some very important points there.